Okay, hi. I chose to do my presentation on restricted and repetitive behaviors. Of course, it is one of the most common issues that we as behavior analysts working with the autistic community come across. And this is also, in my experience, one of the most challenging areas. Um, so I struggled with choosing the topic because I could have done my topic on anything. But I chose this one, and then I got into the research, and it's been a journey. So I tried to make my presentation flow in a way that shows you, the progression of what I went through when I was reading the papers, looking at the research, and coming across different things. So I will first talk about restricted and repetitive behaviors, and then I will talk about a case study, a client of mine, and then I will discuss 2 different studies that I came across. Of course, feel free to stop me at any time and to ask any questions. All right, so first of all, of course, is the definition. Restricted and repetitive behaviors are a core symptom of autism spectrum disorder, and they are in the research. I'm sorry about the noise. I'm at a coffee shop. Can you hear the background noise? Okay, so a core symptom of ASD, and in the research in the papers, it is often described as a stereotyped movement, repetitive use of objects and speech, restricted interest, interest in insistence on sameness, atypical sensory responses. The research also divides restricted and repetitive behaviors into 2 categories. One is higher order, like the insistence on sameness, so repeating the same thing or wearing the same clothes, having like very specific interests, having compulsiveness, kind of similar to what we typically would refer to as OCD, like obsessive compulsiveness, and being very ritualistic and having restricted behaviors. And then the lower order category is stereotype motor movements. So moving the okay. Just had to open the chat. Okay, so typically what is considered to be restricted and repetitive behavior is specifically behaviors that have a negative physical or social consequence. So it has a negative result on the individual himself or the environment around him, and it is mostly maintained by automatic reinforcement. So it is automatically reinforcing, and however, it can also be impacted by social reinforcers for maintaining the repetitive behaviors. Okay, so now that the definition is clear, we can move on to my client who prompted me to do this research and talk about this topic today. AB is a male. He is 20 years old, and he is nonverbal and uses sign language as a form of communication. He has been receiving some sort of therapy since he was a young child, and he's been my client for 7 years. Sorry, I can't hear you. Oh, okay. All right. So he's been my client for 7 years, and he uses sign language to communicate. I currently do with him 2 hours a week of parent training virtually with his dad. Now, he's doing quite well with his sign language, with his communication, but he still has a lot of issues when it comes to ritualistic behaviors. He has a lot of restricted and repetitive behaviors. For example, when they buy nuts or crackers, he would eat a little bit and he would insist on getting rid of the rest. Like the rest of it has to go in the trash. And he is a big guy. He is 20 years old. He is tall, broad shoulders. He's very strong. So what he wants usually happens. And his family, his parents are not able to block him. He also, like when he goes to the supermarket, he would insist on buying huge amounts of food. I remember one time his dad told me that he filled the shopping cart with bananas, just full of bananas. They went home and like he had a couple, and then he insisted on throwing the rest of the bananas out. Like he cannot leave them in the house. They have to go out. He also has a tendency to orchestrate the family's dinner routine. So he makes his parents eat their food, and like then they have to do the dishes and put the dishes in the dishwasher. Like he's very controlling about what his family members do. He also has tendencies, for example, to like walk around the dinner table in circles for ages, like for up to an hour before he eats his dinner. So other things he does is like lots of touching surfaces. It's like he's waiting to get a certain feeling. So he keeps touching a surface, like, it could be his dad's hand or the table until he is satisfied. He closes doors and lights. So for example, sometimes when we're doing the online session and there's a door open, he cannot focus and like pay attention to what we're doing until the door is closed. Like that has to happen. Also, his current reinforcer in the session is coloring pages. So he insists on coloring. He has his dad color pages until until they are fully colored, and then he has his dad rip them off. So it's very ritualistic. Every day it has to be like the same color, the same way, ripped the same. Then they have them ripped the same way. It's like, always a cycle that repeats. The other reinforcer that we stopped was spinning cards. You know how we have maintenance cards? Like, tact, you pull a tact, you pull a card and the learner has to tact it. So we had a lot of these because, we're maintaining his sign language through tacting pictures. But we had to stop doing that because he would insist that his dad had to spin the cards over and over and over again, to the point where it was becoming very inconvenient, and he would insist that his mom does that too, like at different times of the day. And like it was becoming very difficult for the parents to keep the cards around, so they had to hide them from him. So as you can see, AB has a lot of ritualistic and restricted behaviors. A few months ago, his dad took him to a psychiatrist who said it was not OCD. I'm not sure how she ruled out OCD, but she prescribed some medication anyway to help reduce the behaviors. But for me, as a behavior analyst, I'd never really addressed the behavior directly. And the reason I'm doing this presentation today is because, given that this is my role and I've been with the family for a long time, I felt it was kind of a failure on my part to not have been successful with reducing these behaviors or helping the family with managing them. So my question was, now what? Okay, so where do I go from here? Well, the behaviors that the learner exhibits, first of all, are not very risky. So they are inconvenient to the family. They can be very inconvenient, but they are not harmful to AB or his family in any serious way. Like I said, it has not been addressed directly. And the reason for that is the dad's buy-in and his willingness to implement any procedures. The dad is very happy just spending our sessions working on sign language and focusing on communication. In the past, when I tried to work on other behavioral targets like accepting no and waiting, or anything that the dad has to do outside of session, like implementing it throughout the day, or at various points when I'm not there, just does not happen. So even though the dad is, he's keen to work on his on his son's communication, he is not, I don't know, I've never seen his interest in working on those behavioral skills or behavioral targets. The last point that, we have to take into consideration is that AB is 20 years old. He has a long history of getting away with this kind of behavior of, he has a long reinforcement history with his restricted and repetitive behaviors. So I was, as part of my journey of research for this paper, for this presentation, I thought, let's look at what treatments are out there for restricted and repetitive behaviors. And these are the more commonly known things that we've come across, that we've probably tried with other clients. So one of them is functional communication training, the use of visual schedules and cues, interruptions and redirections, response interruption and redirection, physical exercise, differential reinforcement procedures like DROs, DRIs, exposure and response prevention. So I was curious to see what other treatments are out there for restricted and repetitive behaviors. And that's when I came across habit reversal training. Now, to be honest, I came across this about a month ago. I did a CEU where they talked about this, and I found it very, very interesting, that I wanted to look more into it and see what the research out there is. So, habit reversal training is a behaviorally based multi-component treatment. It was developed in the 1970s, and it is usually used with higher order restricted and repetitive behaviors. So for example, for individuals with Tourette's, individuals with tics, typically developing adults who have repetitive behaviors that are outside of their control. So repeating phrases or movements that they don't want to be doing. Okay, so the original treatment package consisted of 9 components. I'm not going to spend too long going over the 9 components, but it was quite comprehensive. So the professional working with the client would work first on response description. So the client or the patient has to describe the behavior, kind of like an operational definition of what the behavior is that they are demonstrating. That's the target behavior they want to reduce, right? So for example, saying a certain phrase repeatedly. Second component is that the client has to be able to detect the behavior. So once they do it, they're like, that was the behavior I'm hoping to reduce. The third component is early warning procedure, and that's basically like a precursor. When the client is aware that he's done a precursor to the target behavior, they can isolate that and be aware of it. Fourth is the competing response practice. So instead of saying that phrase or doing that behavior, they will practice an alternative competing response, so incompatible response instead. And this incompatible response has to be something socially acceptable and more convenient. And then the fifth component is situation awareness training. This is where they talk about like social situations when this had happened in the past. around people and the environment and how it impacted them and the people around them. Component 6 is habit and convenience review. And 7 is social support procedure, which is having the people and around them, the significant others in their life, praise them when they notice that they have stopped themselves from engaging in the target response and instead have done the competing response. So at this point, the significant others in their life are also involved in generalizing and maintaining the intervention. Next, the public display procedure, which is again working on the generalization. And finally, the symbolic rehearsal procedure, which is working on the maintenance. So like I said, it's a very long package, like it's a very comprehensive package. And it has been, the results of this original treatment package was highly effective, and the results were very significant, with 95% of participants that resulted in the target behavior decreasing after 3 weeks of intervention. So this original package was very effective, and in the research, it has been successfully simplified in a lot of studies, and it now has been boiled down to 3 main components. So instead of doing all 9 of these, the research has shown doing only 3 can be just as effective. And those 3 components are now habit awareness or awareness training. So having the individual be aware of the behavior, like they're able to operationally define it, they're all able to detect it. The second one is competing response training. So practicing another behavior instead of engaging in the target behavior. And finally, having the social support aspect and having their significant others involved in their journey to reducing the behaviors. And if you notice here, these 3 components are very similar to what we typically use in ABA. The first one would be like the operational definition, like understanding the behavior and like what is an example and non-example of the behavior. The second one is just like a DRI, differential reinforcement of incompatible behavior. And the third one is caregiver training or, caregiver involvement. So it's funny to see that it's just different names. And I actually like that they've packaged them together. And the research shows that when all 3 things are used together, they can be very, very effective in reducing the repetitive and restricted behaviors. So the simplified version of the habit reversal training has been successful with neurotypical children and adults. But there has been limited research with autistic participants. So its use with children and adults with intellectual disabilities and autism has not been well established. It has been suggested that motivational problems and stimulus control problems often account for failure of habit reversal training in these groups. So because individuals with autism don't have the motivation to reduce that behavior, and they don't have the stimulus control to be able to reduce that behavior, we don't have as much research with the autistic population. However, I went deep into the research and tried to find whatever is out there for people with ASD and to see what the research shows. My first study is by Marcus, Sinat, and Bradley, 2010. It is quite old, but like I said, there isn't a lot of research, and it's only a couple of things that I've managed to find, a couple of studies. The first one is called Treatment of Toe Walking in Children with Autism using GateSpot Auditory Speakers and Simplified Habit Reversal. So in this study, they used the simplified version of habit reversal with the 3 components only. And the study aimed to examine the effectiveness of the simplified habit reversal procedure using differential reinforcement of incompatible behavior, so DRIs, and a stimulus prompt, which is the auditory squeakers, to reduce the frequency of toe walking and increase the frequency of correct heel to toe walking in 3 children with autism. So the 3 children in the study had ASD, were diagnosed with ASD, and their ages were between 8 and 9. Initially, they had the baseline measures, and then the intervention followed. The intervention consisted of 4 phases. 1 is they paired the sound of the squeakers with the receiving reinforcements. 2, the children had to wear the squeakers over the heels of their feet for 10-minute long sessions. And when they walked on their heel and the squeakers would make the sound, the children received reinforcements. Finally, the sessions were extended for longer and longer periods of time, and then they were able to generalize. After they faded out the squeakers, they were able to generalize and maintain the proper walking on the heel instead of toe walking. I'll try to zoom in on the graph. Oops, sorry. I don't know if you can see, but the intervention produced substantial reductions in toe walking across all 3 participants, but the degrees of reduction differed. So as you can see, like this is the percentage of toe walking across 10 minutes sessions, and this is these are the number of sessions. And you can see in the baseline, the frequency was high, or sorry, the percentage was high, and then through the intervention, it reduces. So in this study, oh my God, I'm sorry. In this study, you can see that the use of the 3 components was quite effective, and it led to the great reduction in toe walking. The second study I found, which is a lot more recent, is called Supporting Young People on the Autism Spectrum, Analyzing the Effectiveness of Components of Habit Reversal Treatment. So this paper is from 2022, and it reports on the effectiveness of each of the 3 main components of habit reversal training for young people on the autism spectrum. Now, before I get into this paper, let me just say I will be very critical of it. I did not like it a lot, and it would not have been my choice to present it, just because I don't think it's a very good paper. But like I said, there wasn't a lot of research, and I couldn't find any other papers using habit reversal training with individuals with autism. And at that point, I had already spent a lot of time, like I've committed to the topic, so I didn't want to change it at that point. So I decided to take you on this journey with me, and we can criticize or, look at the study together. Sorry about the noise. The first component of the study is awareness training. So let me clarify again, maybe it wasn't clear. In this paper, they've decided to look at each component individually. So you know how we had said previously that there are 3 components in this package that are, together are good at reducing restricted and repetitive behaviors. These are habit awareness or awareness training, competing response training, and social support. In this study, they have decided to analyze the effectiveness of each individual component. instead of the package. So the first component was the awareness training, and this study looked at a child and an individual, Calvin, who was 4.5 years old. The awareness training is a component of habit reversal training that requires vocal or non-vocal identification of antecedent triggers to the target behavior, or identification of the occurrence of the target behavior. So Calvin had to be able to identify either verbally or non-verbally that the behavior was occurring. Awareness training may take the form of verbally stating that a trigger or a target behavior has occurred, or using other physical indications, such as raising the hand, or such things. So the intervention included, the intervention was specifically for toilet training Calvin, so that he would void in the toilet. Okay. So the intervention they introduced included pre-scheduled sitting on the toilet, along with reinforcement for requests to use the toilet, reinforcement for dry pants, and for voiding in the toilet. As a result, Calvin learned to independently eliminate in the toilet. And the graph shows that, in baseline, he used to have accidents more often, then he had a lot more successes, like 100%, most of the session he would void in the toilet. So their result for the first study for awareness training indicated that it was successful. However, I found it very confusing because the child was just not toilet trained. That, at no point in the paper did it indicate that toilet accidents was a restricted or repetitive behavior. So my first issue with this paper was that, they claimed the use of habit reversal training or treatment, but they're using it with toilet training. So that did not make a lot of sense to me. I'm not sure why that was done. The second study was for competing response training. And the subject was a female, her name is Tammy, and she was 7 years old. The competing response training is also a part of the habit reversal training, and it teaches the participant to perform a behavior that is topographically incompatible with the target behavior. So competing responses should be selected based on the individual being able to perform the behavior for more than a minute. The behavior has to be socially acceptable and incompatible with the target behavior. So Tammy, the subject, had verbal tics. She had delayed scripting from songs, television shows, and from previous and verbal interactions out of context. And she would, for example, sing songs or repeat instructions. So she had a lot of verbal stereotypy, and that was the target behavior for reduction here. And the intervention was that upon observation of the target behavior, this vocal stereotypy, the therapist would begin to deliver high probability tasks until Tammy responded to 3 consecutive tasks in the absence of the target behavior. And then they would deliver reinforcement. So as soon as Tammy would engage in vocal stereotypy or any verbal tics, the therapist would present high probability tasks like, I'm sorry, it's so noisy. They would present her with tact or receptive identification targets or listener responding targets. And then when Tammy had 3 correct responses with no vocal stereotypy, they would reinforce her. The results of the intervention showed that vocal and verbal tics significantly reduced below baseline. So as you can see, baseline was quite high and it reduced gradually. And then there was a maintenance phase and the behavior continued to be low in maintenance. The third part of the study, they looked at the social support component. And for this section of the study, they had a total of 22 participants. So the social support component includes providing favorable comments following attempts of practicing the habit reversal training procedures by significant others, and also like praise for going for periods of time without exhibiting the targeted behavior, as well as the significant others providing verbal reminders for the habit reversal training procedures to help the individual, remember and continue to refrain from exhibiting those behaviors. So in this part of the study, they examined the impact of caregiver support on the acquisition of 22 children and the reduction of the barrier. Okay, so let me clarify. I feel like it's not making sense. So for the 22 participants, they had the scores of the VB-MAP assessment, both on the milestone assessment and the barriers assessment. And the results showed that for the participants who had caregiver training, the scores of the milestone assessments increased for 20 of those participants. So for 20 out of 22 participants, the VB-MAP milestone scores increased following caregiver training. And for 8 of the participants, the barriers assessment scores decreased after caregiver training. So only 8 out of 22. But, still in this scatter plot that you can see in front of you, it shows that the number of minutes of caregiver training compared to the barrier assessment scores, and you can see a lot of downward trends for the 8 participants that had the reduction in the barriers assessment scores. But again, with this part of the study, I found it a bit confusing. And, why would they use the VB-MAP barrier assessment as a measure for repetitive and restricted behaviors? So, all in all, like I said, I am very critical of this study. I'm not a big fan. The reason I chose it is because it's one of 2 papers that I've managed to find on habit reversal training with the ASD population. So as an overview, we can see that the components of habit reversal training are, in fact, strategies that are commonly used in ABA. Like we said, there's the the awareness component is not always there, but the operational definition is something that we focus on, identifying the behavior and labeling the behavior and giving examples and non-examples of it. The second one is the competing response, which we would refer to as differential reinforcement of incompatible behavior, and the social support. What I find really interesting is that together, those 3 components as a package, providing social parent training along with awareness training and competing response training can be very effective. And I would definitely recommend using this package with higher order repetitive and restricted behaviors. So, having ritualistic behavior and compulsive behaviors and insistence on sameness, especially for individuals who exhibit repetitive and restricted behaviors that can be dangerous. to themselves or others around them. And finally, I think that this package is better suited for verbal patients, like individuals who are able to express themselves verbally, who have the verbal abilities to identify the behavior, to have even the understanding of social context, and because that would give them the motivation to want to seek to change their behavior and to reduce it. Finally, I think it would be great to discuss other procedures that you might have come across in your practice. Like, what other strategies have you used to work on reducing restricted and repetitive behaviors? What have you found useful? The other thing is, I wanted to also include in my presentation Greg Hanley's using reinforcements. No, sorry, I mistyped this. Using stereotypy as reinforcement, you're right. It was very late last night when I worked on it. As reinforcement. I wanted to also include it in my presentation, but it's a big area in its own, like that would have been its own presentation. And it is an interesting research for sure. So yeah, this is all for me. And now we can talk about what you guys have had experience with and what the results have been.